بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته، والصلاة والسلام على سيدنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. اليوم هنبدأ رابع محاضرة استكمالا لموضوعات الهايبوناتريميا. النهارده هنتكلم عن practical approach, clinical approach to chronic hyponatremia. If you will find any patient in your consult or inpatient with chronic hyponatremia, how you can approach to this patient asymptomatic, okay? Was not what means this is not acute hyponatremia. Why you correct chronic hyponatremia in our patient? We saw this patient, hospitalized patient, increase mortality and morbidity and length of hospital stay. All this associated with chronic hyponatremia if not treated. Either the patient die with this form of hyponatremia or with hyponatremia, and also associated with high risk of fracture and also CNS manifestation like gait disturbance or cognitive impairment, and also associated with osteoporosis with our patient. We have three major types of hyponatremia. When you see any chronic patient, this patient hypovolemic, eovolemic, hypervolemic. Hypovolemic we discussed in the last presentation. Today we'll concentrate our concentration in the eovolemic SIDH syndrome, inappropriate antidiuretic hormone secretion. This we saw this patient most commonly with the CNS lesions and malignancies. And this classification, as we said, this hypervolemic, we know this was congestive heart failure, cirrhotic liver, and nephrotic syndrome. Eovolemic, you should rule out glucocorticoid deficiencies and hypothyroidism, and the other cause of sciatica, tumor, CNS, drugs, pulmonary disease. And hypovolemic, either many causes. The main causes is renal, GIT and GIT loss, diarrhea, gastrointestinal vomiting, diarrhea, and the patient already was volume depleted. And we discussed this in previous presentation already. Please, this is the most important algorithm done by Dr. Kamil at St. Michael Hospital. You should put this algorithm in your pocket, your mobile, your notes, just to keep in your mind. If you will face any patient with chronic hyponatremia, how you can assess your patient and how can you approach clinically to your diagnosis. At first, you should assess extra arterial blood volume, effective arterial blood volume. And this patient volume depleted or volume overload, eovolemic. Just from systemic examination from hair to knee of the feet. Okay, just general examination to examine your patient is hypo or hypervolemic or eovolemic. If your patient no effective arterial blood volume depleted, we'll go to algorithm no with the next slide. If the effective arterial blood volume is depleted or low, yes, you second step, check your patient in examination. This extracellular fluid volume expanded. If it is expanded, is yes, this means I have this two patients. This patient either congestive heart failure or liver cirrhosis. If the extracellular fluid volume not expanded, we'll go to this side. The condition may be associated with sodium chloride loss, especially with the GIT, diarrhea, nausea, vomiting, or primary adrenal insufficiency, diuretic with low salt intake, cerebral or renal salt wasting. Now we'll go to the second algorithm. If effective arterial blood pressure not low, your patient not volume depleted. Okay. Second step, just ask your patient, you have any medications, thiazide diuretic, and check your creatinine and the GFR. Is GFR is low? Patient on diuretic. If no, you will go to check urine and the plasma osmolarity. If the urine osmolarity less than the plasma osmolarity, if no, you should check urine sodium and chloride if less than 30. If no, you should check this, because this and this, if the urine is low, this means with volume depletion. You should check your patient again, and the urine osmolarity, if more than the plasma osmolarity, you mean also you have low effective arterial blood pressure. We reach here, this is no, and this is no, and we'll go to check serum cortisol and the serum TSH and the free T4, or TSH is enough. If your patient, yes, with this two, any one of this, either secondary adrenal or severe hypothyroidism, otherwise, if this normal, serum cortisol normal, TSH is normal, your patient with clear SIDH. is your clinical approach to any patient with chronic hyponatremia. We'll start by case number 1. Mr. K is a 61 years old male following. He's already post-surgery, post-transsphenoidal surgery with no severe symptoms. Just to call you to see the patient in neuro ICU after surgery. Just he consult nephrology on call to see this patient because his sodium dropped from whatever number, from 30 before to 115 now, and the plasma osmolarity is 250 is low. Plasma serum osmolarity 250 is low, and urine osmolarity 400 is high. Urine sodium 200 is too high. Now we have hyponatremic patient with high urine osmolarity and urine sodium. You remember the criteria for SIDH? Hyponatremia, we have plasma osmolarity, we have less than 270. Urine osmolarity should be more than 100. This forms a criteria of SIDH to diagnose here. And urine sodium should be more than 20. We have this criteria just to remind you. Most hypothyroidism and glucocorticoid deficiency must be ruled out to diagnose your patient as SIDH. Plasma osmolarity should be less than 270, our patient 250. And the urine osmolarity should be more than 100, our patient 400. Euvolemic, the patient on examination euvolemic already, and urine sodium more than 40, and our patient urine sodium more than 200. Urine osmolarity more than 100, now the patient 400. Serum osmolarity less than 270, our patient 250, and with this hyponatremia, this is a criteria of SIDH. SIDH causes. You should put this in your mind. Any patient post-surgery, non-osmotic stimuli, this patient nausea, pain, anxiety, irritable, agitated, post-surgery, all this will stimulate your ADH. Any patient, psychiatric patient, if you consult any patient for post-surgery for hyponatremia, put this in your mind. If the patient in psychiatric consulted for hyponatremia, this selective serotonin reuptake inhibitors, any medication can do this SIDH. Any malignancy, you call oncology department for any patient, whatever the type of tumor, you should priority to put this in your mind. You will go to see one patient of SIDH, especially small cell lung carcinoma. Any pulmonary disorders, whatever pneumonia and other disorders also associated with SIDH. Any CNS malignancy surgery like that, all associated with that. Any patient administered already did AVB will go to hyponatremia, especially patient before kidney biopsy, or any patient with bleeding, especially CKD stage 5 and receiving did AVB will go to hyponatremia. You should suspect this. And the patient transreceptor, this gene, V4 gene, this associated with spinal metatarsal dysplasia. This is an elderly male patient. If patient non-diagnosed from history, diagnosed by this, and consulted you for hyponatremia, you should think in SIDH. Idiopathic SIDH, if all causes rule, maybe this idiopathic. And just a summary for all causes we discussed before, psychiatric drugs, and this CNS lesion, meningitis, subarachnoid hemorrhage, tumor, malignancy, infection by lung, in a lung infection, pneumonia, lung abscess, or brain abscess. Hypothyroidism patient should be ruled out, and malignancy, small cell lung carcinoma. With the picture for to remind you by the most common causes of SIDH. How to manage SIDH is the most important. I need this slide to keep in your pocket, in your mobile, whatever you like. If you meet any patient with SIDH and your diagnosis already established for SIDH, just the first step, free water, not fluid. Concentrate, free water restriction, maybe 500, 800 according to the target weight of the patient. You can put just empirical, and you'll see next lab and the next frequent biochemistry follow-up. High protein intake and salt intake, if not congestive heart failure, or hypertension. If no hypertension, no congestive heart failure, you can recommend to increase high protein and high salt. Increase electrolyte-free water excretion. What means by free water excretion? To decrease just concentration of sodium, potassium, urea in your urine, because all this lights, osmolytes, all this will drag the urine, free water with with this lights through urine, and it will induce more water. There is electrolyte-free water. Loop diuretic, we can do this by using the loop diuretic and increase salt intake. Loop diuretic, what means Lasix, furosemide, or sodium chloride tab, 1 to 2 gram per oral TID. You can start 1 gram BID, and the next lab, next day you can start to increase 1 gram TID and then 2 gram TID according to your next frequent follow-up. Urea, we can start by 10, 15, 20, 30 gram BID or TID. If no, if the sodium chloride not effective, this 13 gram, not milligram, and this 1 gram, all by gram here, okay? Don't follow, as I told you before, and I will repeat again, don't follow frequent your lab monitoring every 2 to 4 hours. For serum sodium, urine lights, urine osmolality, and urine output hourly. As I mentioned for you before, if your urine output increase more than 200 for 2 hours, please take care. Your patient going to overcorrection and they will go to osmotic demyelination syndrome. You should keep the DVB beside your patient to be standby. And some doctors here also receive just using this vasopressin receptor antagonist, tolvaptan or Vaptans. Vasopressin receptor antagonist, Vaptans or tolvaptans. This what is the mechanism of this drugs? This V2 receptor antagonist, this competitive antagonist to V2 receptor on collecting duct, decrease water reabsorption by block aquaporin channel, decrease the water reabsorption from a collecting duct by block or just didn't allow water to be reabsorbed through aquaporin channel via collecting duct and lead to produce aquaresis without sodium loss. Produce aquaresis without sodium loss. خرج ميه will excrete water without sodium. Guideline conflicted for that. FDA already warning it because liver injuries in some patient, no more than 3 months. If you are decide to use, don't use more than 3 months. Not all patients with liver disease, no documented osmotic demyelination syndrome, but reported rapid correction. Benefit is controversial, but this is expensive medication. We are using already on some patients with congestive heart failure and liver cirrhosis, and we'll discuss this later in next presentation. What is the furosemide? We said here in our management, we can use loop diuretic to excrete electrolyte-free water excretion. What is the furosemide effect? It just is a poison to the medulla. Because if you not use furosemide, what will be happening? High medullary interstitial concentration of solutes. From where? From where the medullary interstitial concentration of solute is elevated. This generated by absorption. You remember absorption sodium and potassium via sodium potassium 2 chloride channel in the thick ascending limb of lobe of Henle. Without working this channel, if you will block this channel, the medulla will become diluted by action of counter-current flow of the blood. Similar mechanism post-ATN and post-obstructive diuresis. And this mechanism will help the medulla not to absorb water again and will be excrete more water diuresis than natriuresis by collecting tubules. Case 2, Mr. Y, 72 years, old female with squamous cell lung carcinoma, admitted with pneumonia, sodium 112, plasma osmolarity 250, urine osmolarity 500, urine sodium 50, with no severe symptoms. Stable patient. Just consult you for hyponatremia. We have now hyponatremia, plasma osmolarity less than 270, this with SIDH, urine osmolarity more than 100, now 500 with SIDH, urine sodium more than 20, he's 50 here with SIDH. As we said, this is the same criteria. Don't forget this. Just put this on your mobile, your pockets, your notes when you see any consult for hyponatremia. And same management, free water restriction, not fluid, between 500 to 800 ml per day, and high protein and salt diet. If the patient same no congestive heart failure and no hypertension, and increase electrolyte-free water, it means I will just excrete water only by use low diuretic. Increase salt intake, we can give sodium chloride tab, 1 to 2 grams per oral TID, and you can use urea by concentration 10 grams, 15 grams, 20 grams, 30 grams, PID, TID, according to response and your follow-up. Don't forget this 3 with this 2. And don't forget to follow up your lab every 2 to 4 hours, serum sodium, urine osmolality, urine lights, urine output hourly. And also tolvaptan is the last choice for you. And my home message today, chronic hyponatremia, no severe symptoms, go slow, and go very slow if severe hyponatremia less than 105, hypokalemia, malnourished, alcoholic, liver cirrhosis patient, catabolic patient, and cachexia. Guidelines to treatment: all patients should be on free water restriction, 800, 500 ml per day. Careful monitoring urine output. First sign of overcorrection, as mentioned before. If urine output increases more than 200 ml per hour for 2 hours, this is the first sign of overcorrection. Rate of correction 6 millimole per liter in 24 hours. If high risk of osmotic demyelination syndrome, if low risk 8 to 10 millimole per liter per 24 hours. DDVB if your patient already suppressed ADH and has high rate of correction. Strict fluid restriction, patient will otherwise get even more hyponatremic. Don't exceed 8 millimole per liter per day in normal patient, and if you high risk patient, 4 to 6 millimole per liter per day. And these are our guidelines and reference. If you like to read more and to check more details, ونسألكم الدعاء بالتوفيق، ولا تنسوا الصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. ونلقاكم إن شاء الله في فيديو قادم بإذن الله، وأتمنى تكون الفيديوهات في إفادة للجميع، ونسألكم الدعاء بالتوفيق، ونلقاكم إن شاء الله في فيديو قادم قريبا بإذن الله. السلام عليكم ورحمة الله وبركاته.